Welcome, everyone. Today is our webinar on long-acting injectable, ART. We'll be discussing implementation strategies for this medication strategy in HIV treatment programs. We are recording today, so the recording will be made available through the RAISE and NASTAD websites. We ask that you use the Q&A function or the chat function to ask questions of our panelists at any time. We will have a discussion portion where we will go through as many questions as we're able to. For any questions we're not able to get to, we'll make sure to reach out to you via email. So today's webinar is a part of a monthly webinar series that is hosted by RAISE and NASTAD. RAISE is the NIH-funded Research Alliance in Implementation Science to End HIV hub. It is a part of the University of Washington's Fred Hutch Center for AIDS Research, and NASTAD is the National Association of State and Territorial AIDS Directors. We are a national nonprofit providing technical assistance and support to public health officials who are a part of HIV and hepatitis programs around the 50 states as well as the US territories. Previously, we were the National Technical Assistance Provider for EHE Phase 1 jurisdictions under CDC's 1906, and are currently able to provide technical assistance to all health departments funded through CDC PS 240047. Some of the work that RAISE does is promotes evidence-based interventions, support EHE-funded implementation research projects, connecting health departments to researchers, and then as a part of this partnership with NASTAD, providing technical assistance to EHE health departments on how implementation science can further support your EHE work. So we encourage you all to reach out if you have any questions or would like to meet with the RAISE team one-on-one. We'll be putting some links in the chat shortly, and as well as contact information where you can learn more. And then we just want to let you know that our next webinar in March is going to be focusing on street medicine, and that will be hosted on Tuesday, March the 25th. We'll be sharing more information about that webinar through the RAISE website and listserv, as well as the NASTAD website and listserv. Okay, so our panelists today are Aadia Rana, who's a professor of medicine at the University of Alabama-Birmingham, and also the associate scientist for University of Alabama's Center for AIDS Research. We also have Katerina Christopoulos, who is a professor of residence in the Department of Medicine at the University of California, San Francisco. Donna Sullivan, who's the chief pharmacy officer at Washington Healthcare Authority. James Ben Brock, who's the medical director at the University of Mississippi's Medical Center Adult Special Care Clinic. And our facilitator for our discussion today is Matt Golden, who's a professor in the Department of Medicine at the University of Washington and is also the director of the HIV, STI, and HCV control program at Public Health Seattle King County. So I'm going to turn it over to Matt now, who's going to be facilitating our discussion.
Great. Well, thank you. I want to thank all the panelists in advance for being here. And what we thought we'd do is just start with the group, maybe just giving a few brief remarks, and then we'll address some questions and see if there are questions from the group as well. I think the long-acting antiretrovirals represent a huge opportunity, but there are some challenges in terms of implementation, and that's a lot of what we want to try to get at today. So, Aadia, maybe we'll have you start if you're able to. And I don't know, did you make any slides that you wanted to show the group, or maybe you could just give us your brief thoughts on this?
Sure. So thank you all, and I'm so happy to be part of this panel. I think a lot of experience in this session to talk about and share here. So so I'm at the University of Alabama in Birmingham, and I can sort of speak on two different hats. One from the research hat as the chair of the ACTG 5359 latitude study, which specifically investigated the use, a randomized control trial that investigated standard of care oral therapy versus long-acting injectables in people with challenges with adherence. And so we presented this data at CROI last year, which showed, essentially superiority of the long-acting strategy in terms of less virologic failures in those who are on long-acting versus those who are continued on standard of care oral ART. And so I think both with sort of the FDA approval of its use in those who are well controlled, data from this randomized clinical trial, and then the experiences that I think we're going to hear about from different clinical settings around the country, certainly a lot of opportunity for, or evidence for, its effectiveness in this population. The challenge, Matt, as you mentioned, is implementation. So now with my clinician's hat on, here in Birmingham, we are still very restrictive in our use of long-acting injectables right now. In fact, even more restrictive than the current FDA guidance. Persons, for example, cannot have missed a visit in the past year or have viral load greater than 50 copies within the past year is our current restriction. And so we are hoping from an administrative standpoint to expand that soon, and all of the experiences that are shared today, I think, will continue to help with that. We're hoping to expand starting, I believe, in April to have broader utilization even on those with challenges with adherence. The biggest restriction has been concerns about cost and implementation and whether we're able to do that in a state. Again, we're a non-Medicaid expansion state, heavily dependent on Ryan White and 340B, and a lot of concerns about capacity. So just wanted to put that out there, that while personally a huge advocate for the expansion of use, the reality has been fairly restrictive where I am.
Thanks, that's super helpful. Katerina, maybe you want to chime in here, since I know you guys have been using the long-acting some in people who are not virologically suppressed. You're muted.
Here we go. Hi, everyone. Thank you for being here, and thank you for the invitation to be part of this conversation. I'm Kat Christopoulos. I am an infectious disease physician who has been working at Ward 86 for the past 15 years. Ward 86 is the safety net clinic for the city and county of San Francisco. We have a large clinic of about 2,000 patients. I also have had for the past 5 years an R01 called the Modern Art Study, which has been evaluating the rollout of long-acting injectable cabotegravir and rilpivirine, not just in our own clinic, but also at the Ponce de Leon Clinic at Grady in Atlanta and at the University of Chicago. And through this R01, we've been able to do both qualitative and survey work pre-implementation as well as post-implementation with early adopters. We have done a cost analysis that was just published in AIDS and focusing on those who initiate with viremia. And so I do have a couple of slides that I thought might be helpful to show, just 4 or 5 slides, just to get us started. Let me see if I can screen share here. Hold on. Can everyone see that? Yeah, okay, all right. Sorry, I don't know if I'll be able to get out of this rehearsal view, but I just wanted to let me move up to this slide actually. One of the questions is about selection of individuals or who should be on these, and I think that this is from a paper we published in JIAS. It was qualitative interviews with early adopters. And I think that, there are logistical, psychological, social, and care engagement burdens for both oral ART and long-acting injectables, and I've tried to lay out some of them here, but it's where the burden lies that it really kind of impacts people's motivation and use of these therapies. And so really because when you think about, well, what is the difference that you can make in someone's life, right? What is the psychosocial benefit of this therapy for people? Because this is what really is gonna drive their adherence to the treatment. And it really depends on the extent of the burden that's conferred by oral ART. So some of the benefits that have been well described in the literature, even from the qualitative work that was done in clinical trials, is increased in convenience, reduced anxiety about forgetting pills. Some people feel like it gives them increased control over their disclosure of their status because they don't have pill bottles around. There's a sense of freedom and normalcy. But for those who initiate, and then also there is this positive feedback loop that happens. If you're adhering to therapy and you're coming and you're making your appointments, your providers are happy, and so on. But I think for people, and so in general, there's kind of a thought that these might be less work than oral therapy for some individuals. And indeed, if you really struggle to take pills every day, there is this ripple effect where it opens you up to the energy that you were spending focused on that daily adherence allows you to then focus on other aspects of your health and wellness. This is something that we saw. But I think the kind of maximal psychosocial benefit is really experienced by people who are starting with viremia. And this is really driven by, having a lot of shame and self-stigma about the inability to adhere to daily pills. And somehow what happens is you achieve quote unquote good patient status by coming to your appointments, right? And I just wanted to share two quotes from two of our patients at Ward 86. And, really, I won't read them, but you can say, you can see here, about people would come to their appointments and they would feel badly, right? Like nobody wants to be unsuppressed, right? And all of a sudden, you see your viral load become suppressed, and it's really a very strong driver. And the second quote is from a patient who described how he would get high before coming to clinic, and but now he doesn't have to do that because he feels so much better. And I think that this is really powerful, and it really helps center, why we might use some of these treatments in people with who have challenges to oral adherence. And I'm going to skip ahead right here. And so this is from a paper Matt Hickey and I published in JADES about thinking about this in kind of a 2x2 table of suppression and care engagement status, because there is a group of people who come to clinic a lot, right? They're just not taking their meds. And that's where there's really a clear potential for high impact, and where you can start small and really try to figure out the things that might work for this group. And then, of course, there are people who are not taking their pills and really not coming to clinic that reliably. And so, what are the things that can be done to really shift these people to the retained category? Frequently, they might not be retained in clinic care, but have a relationship with a provider. UW has pioneered the work in low barrier care models in terms of, facilitating drop-in care, small incentives to improve engagement, really trying to maximize retention before starting these therapies. And then, of course, moving to out-of-clinic injections through home nursing in our DPH home nursing program. That is something that we've had to do. But just to turn a bit to some of the implementation strategies, as mentioned, this is a complex intervention, right? And so, I think just to say some of the things that have really helped us at Ward 86 is the development of a clinical protocol. It's posted publicly on our San Francisco Getting to Zero website. A small pilot phase. So starting small, right? You don't have to roll this out to everybody. You're going to start with 5 patients. And I think for us, what was really key is that our first patient was actually someone with viremia. We didn't wait to quote unquote work out the kinks in the system with with folks who were well engaged. We started with both suppressed individuals and folks with viremia from the beginning. I think realizing, what are the facilitators in your environment? for those who are giving 3 penicillin injections for latent syphilis, there is that glimmer of an infrastructure there, right, where you have to bring people back. Now, you're only bringing them back every week to do it instead of, every 4 weeks or every 8 weeks. But, building on, if you have a nurse for drop-in injections, how can those kinds of things that are present in your infrastructure be leveraged? At Ward 86, our efforts are centralized in a pharmacy technician. So this is our model, where the provider is referring to the clinical pharmacist to review eligibility and provide education, and then really the pharmacy technician picks up most of the logistics. So ensuring drug coverage, inventory management, interfacing with the specialty pharmacy. In academic centers, we're really quite lucky because it's usually the hospital pharmacy that's going to be the specialty pharmacy providing the drug, scheduling injections, monitoring, interfacing with providers. Of course, nurses are giving the injections, and then there's wraparound services from other members of the care team. And then just here's some qualitative data, kind of in support of this pharmacist technician models, which is really, providers are too busy to handle these procurement logistics and the tracking logistics, right? And so, this piece, really allows, frees up the provider to offer this, really, because they're the gatekeepers. However, the pharmacy team is also going to need support, right? So if somebody doesn't come and there's a question about dosing, or a viral load comes back and it's 89, right? There needs to be a clear channel of communication with the physicians around these complex situations. And so for us at Ward 86, we do have an ongoing multidisciplinary case conference where everyone's coming together to discuss these challenging cases. And then I think I'll just stop there because I don't want to take too much time, but thanks.
Thank you, Kat. That's great. Ben, maybe you could tell us about your guys' experience in Mississippi.
Sure. I won't start with the William Faulkner quote. Everybody's had such great comments. What can I add to that? We, at the Adult Special Care Clinic at UMC, we're a site for the customized trial. So, the manufacturer instructed us that patients were going to move to commercial fairly early. So we had a cohort of around 13 patients that had to very early get on medications. And so we had to figure out how to make this work fairly early, around the time of FDA approval. We have had multiple different iterations with our team. It started out with a pharmacist-based model where our specialty pharmacists were driving the approval and scheduling the visits and sort of scheduling the follow-ups and making sure that people were coming. They quickly became overwhelmed by that. With direct-to-consumer marketing, patients were beating down the doors to initiate this therapy. And we were fairly open with allowing patients who, were virally suppressed and met criteria to start the treatment. And it ballooned pretty quickly, where we moved to a case manager-based model with RNs. And eventually our regular RN case managers felt overwhelmed with it. And we allocated a specific nurse to drive this program, who both administered the injections and did the wraparound case management. The relationship building there has been very strong. And so our case manager often is confused with the provider at this point, and they'll call her with issues before calling the doc. I agree. Very early on, it was clear that viremic patients were those who have the potential to benefit most. And I don't want to discount the benefit that patients who are virologically suppressed get out of this. And there have been fantastic anecdotes, especially around pill stigma, patients who either don't have to have that daily reminder that they're HIV positive, or anxiety around a missed dose. And there have been a lot of anecdotes around that a weight has been lifted and their sort of mental health is in a better space, even though they're already virally suppressed. And, from the clinician standpoint, doing well on their oral ART. But we have opened it up to a handful of viremic patients, and we did report that in CID as well. But it is really amazing to see patients who you've tried everything. You've really put in all the resources that the clinic has to try to achieve viral suppression and just are not able to. That long-acting therapies have the potential to sort of take adherence out of the window. And there are definitely some logistical challenges that I'm sure we'll get into in how to properly manage those patients and the risks of making that decision. I think panels to decide that before just initiating that in somebody is appropriate to make sure that you've kind of exhausted all your alternatives, because the potential for virologic failure in these patients is higher, and when they fail hard, right? So.
Thanks, Ben. So Donna, maybe you could end for us. So Donna works
Sure.
for the healthcare authority, so maybe a different perspective than our other people.
So I'm a pharmacist by training. I'm the chief pharmacy officer, and I oversee our Medicaid pharmacy program as well as our public and school employees program. These are great drugs. I think there is the possibility of the long-term suppression. I do believe, compliance can be an issue with many of our clients. I feel it's unfortunate the price of these medications is going to make cost the primary reason why people will be restricted to these medications. We have, if you're looking at for PrEP, 850 people, actively taking oral PrEP. That could be a significant impact to a payer's budget, whether that be a Medicaid program or an employee program, and potential impacts on premiums and members out of pocket. So I believe that's unfortunate. I think these are wonderful drugs. We do currently cover them in Washington without any restriction. So I'm glad to hear, it is nice to hear that the providers are really reserving these towards people that maybe benefit from them the most. And I really appreciate the work that you're doing.
Great, thanks, Donna. So I guess I'd put out to the group, you've raised important issues about two groups of people, those who are not virologically suppressed and people who are virologically suppressed, but perhaps who just want it and would benefit in other ways. And how do we balance that in terms of this cost consideration and burdens on the clinic, which are also not inconsequential? Maybe, Ben, you could start.
Well, the real cost of the clinic are the additional visits and staff, and the staffing costs are not, they're significant. We currently have 3 full-time RNs that are just managing this program, and they do take some of the burden off of the clinician staff and additional case managers. But outside of grant-funded programs and especially 340B revenue to be able to fund those additional staff, I don't know that provider billing and pharmacy revenue without 340B would be able to accommodate that. And I think smaller programs, particularly that are not as resource rich, are going to be able to implement this as effectively if you can't allocate additional staff for this. As far as the cost of the medications itself, monthly bictegravir combination tablets, for instance, are also quite expensive. And if you're moving to the Q2 month injection, I guess it depends state by state, but ours are fairly comparable with the Q2 month. It's the cost of shipping, storage. We had to buy additional refrigerators. We now have 2 full-size refrigerators just for our cabotegravir, rilpivirine. So,
Although I would point out, Ben, as you probably know, Biktarvy's a high-cost drug, so you're comparing it to the highest cost drug option that you have, although also the most commonly used drug. I know, Kat, would you have thoughts about this?
Yeah, I mean, I think the real I mean, if there's going to be a cost savings or cost effectiveness, it will be in probably the treatment of individuals with viremia. I'm going to put in the chat a link to a paper we just published on this, where using data from the Ward 86 clinic, where, you know, we took our last published, you know, this is just looking at the first year, right, where we had over 48 weeks a viral suppression rate of 92% in our Cabril cohort. And we assumed for the people who have these intractable adherence challenges that they would have a viral suppression rate of about 15% over the course, you know, so this is people who have sustained suppression over the course of a year, you know, that the difference in the cost of care was about 21,000. So the incremental cost per newly suppressed person was about $20,000. And so that long-acting Cabril would be, you know, cost effective above that threshold, if you're willing to, at any willingness to pay above that level. You know, and I think you know, there have been some cost analyses from sub-Saharan Africa suggesting the main thing that, you know, if there's going to be any cost neutral or cost effective impact, it'll be in treating those with a viral load over 1,000. So.
Did you have thoughts about this?
Yeah, so I think that, you know, in developing these programs, it's interesting to think about the different structures that are necessary for like certain groups of patients, right? Like we see our patients just regularly for clinic visits who show up on their own, don't need phone reminders, are like A-okay, and they have that capacity, right? And then we have those who just for their clinic visits, like need transportation, need constant reminders, need the case management. And in my mind, that's how I split up this service as well. So there are going to be those who want it and are self-promoting and think this fits in that schedule. And so the cost is a little bit different for those folks beyond the cost of the medication and storage versus those who I think would benefit from obviously personal outcomes and then public health outcomes. And it's kind of hard to sometimes tease this out when you're making a bid to your administration to say how much this is going to really truly cost. I think I would be interested, I think, in a couple of things from the panel and maybe others who are doing this myself. It's one of the things that we think about when we're trying to develop our program here is do we have a target as to what proportion of our clinic population, whether it's suppressed or challenged, can we have? We have a clinic of 4,000 patients. So, and right now, even with, I mean, we have about almost 200 people on injectable, mostly who've come off of studies like Latitude or Trial or Atlas and Flare or are coming on. So it's not that we don't have people on long acting. We already have 200 people on long acting, but what could we do given our resources as a Ryan White clinic, potentially with some 340B funding? Like, is there a target that people have in mind? And of that target, you know, when we create the programs, Ben, you mentioned you have like RN case managers. Are there ways for us to incorporate support that isn't that expensive? And I think, and Kat, you were mentioning in sub-Saharan Africa, where they are so much better at like decentralization and using things like community health workers and such to support, and how we could potentially learn from that and add that, especially when we're trying to argue for expansion of these programs. So those are some of the things I've been thinking about, like what do we have a target in mind, and how can we kind of decentralize that very much needed support that could be specifically for our viremic patients.
Donna, do you have thoughts about this issue?
Not much different from what has already been mentioned by the other panelists. with Washington, we have I can have what my opinion is versus what we're able to do. In Washington state, we have a budget proviso that prohibits us from putting any restrictions on these medications right now. So we're really dependent on the providers that are steering them towards, patients that would, most benefit from them. And it's just really a challenge for us from a payer perspective. Looking also not just the medications, the long-acting injectables that are currently on the market, but looking into the pipeline and what is coming down the market as well, and trying to look to how we can provide access to these medications, but also, trying to control overall cost.
Aadia, I wanted to come back to your question. I really like this idea of, well, what's our target? So you have 4,000 people in your clinic. Let's say you have 20% not virologically suppressed. That's 800 people. Do you have capacity to go beyond that 800 people to the people who want it just because they want it, but they're already virally suppressed? They can't be doubly virally suppressed.
I don't know. We don't even have right now capacity to go to half of that per se, the way that our program is structured right now. But I also think we have to take into consideration that even those who, it's not a panacea, right? Like, there are going to be those who are not virologically suppressed who are either not going to want it or potentially not going to benefit from it because they have resistance or, side effects or allergies or whatever it might be. But I wonder if that would be a potential benchmark for us to consider in our advocacy, that you should consider that as a potential target. And if not, why not? Like what could you do overall? I'd be interested to hear for the clinics that are currently using it extensively, for their entire patient population, how many of them are those, what proportion overall, and then how fall into the category. But then, Matt, as you know, with the caveat that engagement and suppression is not continuous, right? It's seasons so the people who are doing well and we switched them to long acting, they may not do well later, and vice versa. So it's sort of hard to pinpoint that directly.
People have thoughts
Yeah,
about this?
I just want to make two comments. One is that when you're, when we're assessing viral suppression in our clinics, it's really important to, not to rely on these point in time estimates, but for example, we looked over a calendar year to see how many people were, continually virally non-suppressed, right? And that was about 10% of our population. So that's a little bit, of a, I guess Ryan White Clinic's viral suppression is quoted around 90% generally, but it's that last 10%. But I will say that, we have a lot to learn still about persistence on these therapies, and we'll be presenting some data at CROI on our discontinuers because people do stop, right? So we've been doing this since June of 2021. We're 3.5 years in, and it is, right, not for everybody because of pain, mostly because of pain, actually, or plus minus other side effects. But I think, as time goes on, learning why folks stop is going to be really important as well.
And you have thoughts about this balance and what sort of targets we're looking at?
Yeah, I don't know. We've been fairly open to offering it to anyone who asks, and it's a question that's coming up. It's the viremic patients that we've been much more conservative with, and now we've got 24 patients whose viral load was over 200 when we initiated. But again, as mentioned, virally suppressed patients may be have similar issues and persistence and social needs. So I don't know how to really quantify what a target would be. It's hard to say no to somebody who asks for it, I'll say. And our clinicians have had a really hard time saying, I don't think this is right for you. You're doing fine on oral therapy. So.
Yeah, I think that is hard. Before we go off this issue of costs, I want to raise one last thing with the group. So we're probably in 2027, dolutegravir goes off patent. At that point, in all likelihood, within a year of that, we'll probably be able to give you a first-line antiretroviral therapy for $1,000. Price will drop 95% if it's like PrEP. So these meds are going to cost 20 times as much as that. 11% of people living in King County with HIV are unhoused. Why are we putting the money in the pharmaceuticals instead of the housing? Is this really where we want to put the money, particularly if the people are already virologically suppressed? I recognize I'm being provocative.
That changes the whole dialogue as it did with PrEP. You know, when Truvada goes generic, the cost analysis with injectables or with commercial oral completely change. And we'll be having a different discussion in 2 years. I can't wait to attend the talk. But also having combination tablets that are non-integrase inhibitor combinations that are available is not the same discussion as having an integrase inhibitor combination that's currently, you know, a first-line therapy in the DHHS guidelines or IAS, whichever you prefer. Yeah, I think that the cost benefit will not be as clear, particularly for people for whom oral therapy is a viable option.
Yeah, I guess I'll push back. I think, Matt, you're looking for a little pushback, so I'll try to push back a little.
Agreement.
But I mean, I guess, okay, so two thoughts here. One is that, you know, when we think about our folks who have the most trouble, they're not on integrase-based oral therapy, right? They're on darunavir based oral therapy, right? Because the thought is that it will be more forgiving in terms of intermittent adherence. So that's one comment. I guess, you know, a second comment is that, you know, housing may not change the relationship people have to oral pills, right? Some people just cannot take oral pills because it gets stuck in their throat, because, you know, the disclosure concerns, so I think how you tease out that issue, you know, where is it that, you know, housing and, you know, more stability, life stability is going to make the difference versus, you know, a pill versus an injection is something else to consider. And then I guess, you know, the final point that we haven't talked about too is that for those with resistance, you know, one thing that we have started to use in our clinic and other clinics have started to do as well. And I believe that there is a small ACTG trial planned on this topic, is using lenacapavir with cabotegravir. So an every 6-month injection paired with an every 4 or 8 week injection.
I wonder, before we turn it over to the group, do people have additional comments they want to make on the sort of implementation issues at the clinic level?
One thing is the tie-up and workflow. You commented about syphilis injections, and our nurses did struggle to implement injections for long-acting ART in their already busy workflow. And so having our nurses who are just there to administer the injections meant that the clinic workflow wasn't as disrupted. And I think that's one benefit of having a healthcare staff who's over it, over community health worker, for instance, is the ability for it not to disrupt clinic workflow.
Jan, you have your hand up. Do you want to have a question or a comment?
Yes, thanks, Matt. I've got a question for Ben, Kat, and Aadia on this kind of implementation point, and perhaps this is a bit concrete, and you may not be able to answer this question if you don't feel comfortable. Hopefully it's not that personal, but how did you get your institution to pay for the individuals that you need for your long-acting team? So Ben, for example, you were talking about your nurse case manager. Where did that money come from? Where did the farm tech money come from? Yeah, a question for all three of you, if you feel comfortable sharing. Thank you.
So I don't have any of those things right now. Our current program is 100% funded through our Ryan White program and what we get from 340B. So we have one nurse who's full-time doing all of the case management and scheduling, although administration is split among, we have like procedures, things, they come in for syphilis shot, they come in, so it doesn't matter. But the main organizer is 100% funded. This is their job and this is what they're doing. That has been the biggest limitation and expansion of our program. What we have proposed as helping is to, and I think everybody will agree, and not just because Donna is here, but you always increase the quality of a care program delivered when you include a pharmacist in your program. And so we have now asked the hospital to support this program with a pharmacist. They will get some financial benefit through their 340B programs that are hospital-based. And we've also asked them to include not just treatment, but also prevention opportunities, so that the pharmacists are brought on not just for the Ryan White part, but then we have a separate, as you know, the funding has to be, crystal clear. One is for treatment, one is for prevention, but that is a hugely expandable role. And so that's how we're arguing for having the hospital help fund that program. But primarily, and then, we can have some sort of like pilot grant support through different hospital funds, but we're really trying to build it in terms of like long-term sustainability in that way.
Others have thoughts about this, how you engage leadership in building the infrastructure?
Yeah, I think it's always a little bit opaque, right? But I do think, in our clinic, we had pharmacists and pharm techs, before the long-acting program, and those have been scaled up. But it is, I think it is, and it's interesting. I mean, we're in a DPH system, and so we're not billing, we're all public insurance, right? And so sometimes it's a discussion with the Department of Public Health in terms, because the pharmacists aren't billing for their services, right? And then I think in other situations, like for the low barrier care clinic, pilot grants show proof of concept, and then you're able to negotiate for more money. But yes, it is a little bit of an opaque process.
We're Ryan White Clinic, but we're also a hospital-based clinic, and 340B revenue funds almost all of our staff. The hospital provides very little support for staffing, but to that end, we have a lot of latitude to be able to bring on new staff because it doesn't require the upper echelons to approve it. And so it allows us to be pretty flexible, but at the same time, it's a house of cards. And so we're really reliant on that revenue to be able to do the programs that we do.
You guys have experience engaging your Ryan White planning councils on this? I mean, it seems to me that particularly insofar as you concentrate on people who are not virologically suppressed, you can, you potentially have a good argument for the planning council. Most jurisdictions have such a body since it's required. So maybe not all have experience. I do think that there's an opportunity there in some places.
Matt, I do have one last comment. For clinics that are not necessarily associated with a hospital and using a hospital pharmacy as a specialty pharmacy, have you had any challenges with when you do have to go through a specialty pharmacy where the patient doesn't show up for their appointment and the medications has already been billed to that person's insurance and delivered to the clinic, so the pharmacy can no longer take that back and the medication then becomes wasted? I could see where implementing injectables, long-acting injectables, and clinics not affiliated with a hospital pharmacy or a pharmacy of some sort, that they might have challenges with wastage. We've seen that with other long-acting injectables that are driven through specialty, primarily like Suboxone and Brixadi, that clinics don't have REMS certification, so they're ordering through the specialty pharmacy, and they've mentioned that they do end up having wastage.
We only use the UMC specialty pharmacy and ADAP, and so we haven't encountered that issue if it haven't been shipped from another specialty pharmacy, but we have been able to reverse claims on people's insurance plans and then use that medicine for another patient since it's already been shipped. I've had it drawn up and ready to inject in a patient before and had to reverse the claim, and making sure that it meets the storage criteria to administer it for somebody who's scheduled for that same day as well. So.
You know, Donna, I think you raised a really good point, though, that the experience here, myself included, is working in academic medical centers, which have large Ryan White funded clinics, which of course are critically important in this whole process. But in terms of trying to push it out into rural parts of our state, for example, there are other challenges, right, in doing this. Do you guys have any thoughts about that?
Well, we just wrote a grant actually, and it got a great score. I don't know. We've been told they want to fund it, but don't know if that will happen. But we will be working actually in Chicago with several federally qualified health centers that use Walgreens specialty pharmacies, community Walgreens specialty pharmacies, 2 of them, to that those would be the pharmacies that that supply these FQHCs. And so we are going to learn about this issue within the next study, but can't speak right now to that.
We have other questions from people who are in the audience or participating.
Matt, there's one question in the chat about using these long-acting injectables amongst pregnant folks, and if there's special considerations there, or folks on the call have had experience with that.
We have a very small number of women in our clinic, and I think we've had one person who went back to oral ART during her pregnancy and then continued, but I think we've also had one who continued on long acting. And again, in our clinic, once someone becomes pregnant, they're really taken on by a specialty HIV program, the Hive program, BAPAC Hive, that really holds them very closely during their pregnancy. I know from speaking to colleagues at the Ponce Clinic in Atlanta that they have had at least one pregnant patient, if not more, continue on long-acting Cabril and have a successful delivery and a good outcome. So.
Yeah, I mean, unfortunately, there's very little publication. I think I'm looking at the chat, and there's the one sort of experience, and I think there's been some in compassionate use. In Latitude, we did have 2 pregnancies for those who are on long acting, and we'll be presenting that. And I think also in the CARE study internationally, so that was people who are doing well, and so we're eligible to be on their oral therapy, and then we're eligible to enter into CARES, which randomize continuing on their oral therapy or long acting if they had already received long acting, or if they had already received a dose of long acting when they found out that they were pregnant. They were able to continue, and then similarly, I think the outcomes were not any different than those who were on oral in terms of the pregnancy, at least not statistically significant, although there weren't very many. And so, I mean, if in those with challenges with adherence during pregnancy, I mean, it essentially goes back to compassionate use. Like, is this the only potential option? I think at the Ponce Clinic was a patient who actually needed both Cabenuva and lenacapavir. And so that somebody who had a lot of multi-drug resistance and also was not going to take, like, was refusing to take any oral therapy. So there is some, utilization being done in that population. I think there's a question about injections are painful. I think that's true. And I think in most cases, they are doing, from my understanding, for maybe the one in Ponce and others, they're doing monthly injections in that population. There are concerns about rilpivirine pharmacokinetics, particularly in third trimester, and then considering using 2-inch needles in that population as well.
Other questions from the audience? Or comments about how people are using these drugs? I think that would be interesting to know. I guess there's a lot of unpublished experience out there.
Matt, what's happening in your setting?
So actually I believe that Elaine Thomas is on, and she can talk about, Elaine, if you feel comfortable, maybe you could talk a little bit about what we're doing in Mac's clinic. Assuming you're not seeing a patient.
Hi. Sorry, hold on. Yeah, I have been helping out with our clinic in Seattle, and we have a little over 20 patients on now. Some of them are around a year, and at least one is a little more than a year out. We've had very good success. These were all unsuppressed people with lots of challenges with adherence who were just not, some of them were doing very badly. Some of them were, high viral loads, no oral adherence whatsoever. Pretty much everybody has slammed their viral load down to undetectable or near. Of course, like you guys are saying, the concern is going to be with persistence and resistance and seeing what happens over the next year or two. But so far, it's very exciting. Our clinic does have the capacity. We're using a couple of nurses and an MA, and I can't speak to FTEs, but we have an outreach team that Matt could say more about, but they're helping with in-home injections for a few of these folks that have trouble getting in. So there's a lot of staff time involved, and I think we don't, as we ramp up, we're going to have to say, how much staff time do we have and how much do we need? We're sort of not there yet. I think Jihan is on too, and she could maybe comment, but so far we're extremely excited about these patients for whom nothing else has worked.
Sir, from a broader perspective, we're hopefully in the process, this will start today, going to develop state implementation guidelines for the use of long-acting drugs, which I think will focus on those who are not virologically suppressed. And I really think, but we'll see what the group thinks. But the opportunity, I think, is in the people who are not virologically suppressed, and that's where we need to focus our efforts. And while it's nice to give people, whatever they want when you can do it, I don't know. I guess we're pretty focused on those who are being left behind. So that's where I would like to see it go. It's a huge opportunity, right? And we really want to make sure we're doing this right, it seems to me. But there's always a big engagement process, right? There are a lot of voices, and I know different parts of the state are doing different things. But
I also think it's as we're thinking about these, I mean, obviously the focus right now is on cabotegravir plus rilpivirine injectable. But as we know, in the pipeline are other agents that are coming. So whether we're talking about, the addition of lenacapavir or like weekly oral therapy and all of, with lenacapavir plus cabotegravir, or even monthly potentially, or even more long acting. And I think taking some of that future into consideration when we are speaking to our administrators is helpful. you know, and saying, you know, we're not just opening it up for this time period, but here's the potential, or this is the direction that we're going anyway. And I think it's interesting for us to think about, you know, when we think about things like one of the big cells for Cabenuva for its uses, we talk about its DOT, like you can't, you know, unless it's leaking out or something or poorly administered, you know, you're taking the medicine, and DOT has been unsuccessful for oral ART. It's not feasible, and the daily requirement is tough. But are there systems that we could also set in place once we're considering weekly or monthly? And can we leverage the same existing systems that we're building? And would there be less cost to that potentially? I don't know how much these medications are going to cost, Matt. That's probably going to be the key question, especially if dolutegravir becomes, when it becomes off patent. But I don't know. I think it's, you know, even sites that don't have the pharmacies that are, or the 340B or the hospital-based pharmacies really need to think about how we can leverage the future antiretroviral therapeutics into our existing clinical structures.
I think that's exactly right. I mean, it's really an ideal drug for contingency management, isn't it? It's perfect for contingency management because you walk in, you get your reward simultaneous with your injection.
It's to piggyback on the comment about the Max Clinic cohort doing so well. You know, we as clinicians and our case management staff do our best to try to predict who would be a good candidate, but we are imperfect, and so we're withholding the therapy for people who might do well on it. And then there may be patients who are virologically suppressed right now who aren't such great candidates. We have taken geography into that equation, but you know, we try to lump visits together with transportation assistance, that sort of thing. But the kinetics of this medicine with the viral load data are sometimes a little concerning and unpredictable. And if somebody's on a modern oral therapy and they stop it, usually it's not associated with virologic resistance. But we have people who have failed in our clinic cohort who were doing fine on oral and then develop virologic resistance despite getting their injections on time and being administered appropriately. And then patients who were viremic and have been doing fantastic. So it's kind of a mixed bag and a double-edged sword there, but it's been a challenge to really guess who's going to do well on it. And I do have some concerns around people failing who were doing fine.
A good point. Others have thoughts about that? I think across the studies, and it's very hard to lump them all together, and yet I have done that in a slide, it's about 11% viral resistance, but not all the studies report resistance, and the length of follow-up in the different studies is different, and so it's a little hard to know in some ways. I don't know if other people have thoughts about that.
Yeah, and I think, I mean, it's a nuanced conversation, right? Because you can fail with on-time injections, right? And then people fail, you know, our adherence challenge patients often fail in the setting of late injections, but not always, right? And so, you know, you know, sometimes you'll get a situation where someone will have a viral load bump up, and then they get the individual gets really nervous and goes right back on oral therapy, and you don't ever get the answer, right? Like, was this, you know, a failure or not a failure? And so it's very challenging there's no consistency among the studies. It's challenging to make inferences about that.
Well, I think we're out of time. Krupa, did you have any last words? This has really been super helpful, and I appreciate all of our panelists taking the time to educate us.
Yeah, thank you all so much for joining us today, and we hope we'll see you next month for our next webinar. Thank you to all our panelists. Have a great day, everyone.
Thank you. Bye.
Thank you. Bye.
Bye.